It's been 25 years since I used to work in the emergency department at Prince Alfred. And I know that because as I was chatting to one of the young nurses there, I said to him, I last worked here in 2001. And he told me he was born in 2001. So that made...
Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data. Proudly brought to you by Pulse IT News. This is our Hot Topic show and I'm your host, Louise Schaefer.
I'm your other host, George Margellis.
George, it's so lovely to see you and you're wearing a jumper today. That is rare. I don't often see you in the long sleeves.
It's getting a bit cool down here in Sydney. It's probably nothing compared to Melbourne, but you've come back from a heat wave, so I guess you probably don't even noticing it anymore.
Oh my God. I got back literally hours ago and it's 12 degrees, but it feels like 8. The whole time I was in the UK and France, it never went below 25 degrees and most days it was 30 plus. So yeah, crazy heat over there and no one has air conditioning. George, the other day I was at RL Datix's conference having a great time in Telford and it was originally going to be one train back. Well, I ended up in 2 Ubers and 3 trains to get back because of the heat wave and everything had to be rerouted and it was a problem. And then I finally got on the final train, which was going to be 2.5 hour journey, no aircon. And it must have been 33, 35 degrees. I was laughing at the UK people walking around with these portable plastic fans. And I'm like, guys, toughen up. It's fine. On that train, I was seriously thinking, I wish I had cash because I would just say, here's £100, give me your fan. Like, I need it. It was so hot.
Yeah, it's been all over the news here and they've obviously had some major health issues because of the heat. And Spain's having fires. But here it's nippy, but it's the sun's shining, so we can't complain. A bit more about what you did in your whirlwind tour of Europe.
Thanks. I had such a good time and it was such a luxury to be away for a few weeks working. But yes, I did do paragliding. Thought I was going to jump off a cliff. Apparently, you basically literally run off the cliff. I loved it. Like, when you're a kid and you dream about flying, and I believe some people float through the air and other people flap their arms like their wings. Well, I'm a floater when I dream about flying. And I think paragliding is the closest experience to that I will ever have in real life. And it was beautiful. I was 3.5 kilometers above sea level, saw a glacier, saw these crazy humans climbing up cliff faces. And I was like, I felt so much safer than them. And yeah, it was lovely. I loved paragliding.
To that, there's a ride in Disney World called Soaring where it simulates a kite glider, but you're only like 2 foot off the ground. So it feels a lot safer, but that sounds amazing.
Yeah. Oh, it was really good. But the other thing, George, that I did that I wanted to tell you about is I met Nicholas Hamilton, the race car driver. And he is
I did
awesome.
see that photo and I thought, wow, that's pretty impressive. So how did that happen? Well, you weren't on an F1 track.
No. It was very much work. So I was at RLD's event in Telford and at the end of the first day, they had a keynote speaker that was talking about how to overcome adversity, teamwork, believing in yourself, all those sort of themes. And it was Nicholas Hamilton. And I've got to read his book. I wish I'd already had a copy of it because I would have got him to sign it. And he was very kind to agree to have a photo with me. But his story is amazing. For anyone who doesn't know, he's Lewis Hamilton, F1 drivers. It's his brother. And he was making lots of jokes about, yes, I'm not here to talk about my 7 times world leading brother, F1, but he's a very prominent race car driver in his own right. And I'm sorry, but more impressive than Lewis, because while he might not have won the F1, he has won championships competing against able-bodied drivers, and he has cerebral palsy. He doesn't compete in the Paralympics version of motorsport. He competes with able-bodied drivers and wins, and he is awesome and good looking guy, so charming and fun. And he was a great keynote speaker. His story was really moving and really uplifting. It was such a privilege to meet him.
Sounds like a great experience. Yeah, and I'd love to hear more about the rest of your trip when we catch up in Melbourne in the next couple of weeks.
Yes, we're going to see you at, is it a Sparked event, George?
Yep, there's a Sparked event we're focusing on aged care coming up in Melbourne. Then I'm straight from Melbourne, I'm flying straight over to Hong Kong for the Golden Age conference. So it should be a busy couple of weeks ahead. But it's been busy here while you're away.
Yeah, what have you been up to?
I decided that what we need to do for this podcast is embed ourselves in the system and learn more about happens. I actually had a hands-on experience with healthcare with one of my elderly, very close relatives, got admitted through ED. And I used that as an opportunity to check out what's happening in the healthcare system. And I have to tell you, I was pleasantly surprised. So,
oh, that's good. I hope it was a good outcome for your relative too.
It was. First of all, I've got to say, I've got to give a big shout out to the team at Royal Prince Alfred. They did an amazing job. It's been 25 years since I used to work in the emergency department at Prince Alfred. And I know that because as I was chatting to one of the young nurses there, I said to him, I last worked here in 2001, and he told me he was born in 2001. So that made...
Oh, I hate when that happens. No, how's that physically possible?
So that was pretty cool. But the experience was really good. We got into ED. It was chock-a-block. The waiting room was full, but they took them straight in because they're quite sick. They kept an eye on them. They escalated into resus bay when things were starting to get a bit hairy. And the care in the ED, I have to say, was amazing. But then when we moved on to the ward, I was even more pleasantly surprised by the level of care there. So the nursing staff on the ward, so this is an elderly person with significant health issues. The nursing staff were just all over her. They managed everything. They arranged wound management. They arranged hospital in the home for when she got home. They arranged virtual wound care when she got home. The experience was pretty spectacular. So I have to say, this system, when it does work, works really well. In this particular case, it may have helped that the noisy family member who's got a medical degree and has a podcast may have helped drive some activity, but no, it was really good. And I just want to give a shout out in particular to two nurses, Natalie and Patrick. They both did an amazing job. And the digital part of it was amazing. There was workstations everywhere. They were using the technology well. They were sharing images of wounds and getting referrals from senior staff over the weekend. It was a pretty good experience. Kudos to New South Wales Health and Royal Prince Alfred. And Richard Taggart, you're doing a good job. Well done.
Oh, that is such a good story. And yes, good on you, George, for shouting out to the two nurses as well. It's great when you go above and beyond and it gets noticed.
Seeing the real world experience is eye-opening. The system does work when you enable it to work. I did actually get to see the Minister for Industry and Innovation. I attended a talk he did with Annette Schmid from the Digital Health CRC, looking very much at the role of innovation. Annette and I made sure that he highlighted the fact that healthcare is one of those huge areas of innovation that they need to talk about. There's been some changes in the recent budget that are causing some concerns. So there has been some changes happening there to correct some of those issues. But I think that, again, the fact that we have a Minister for Innovation who makes sure that there's work happening in the healthcare space, I think is very important.
No, that's great. And good opportunity to get the ear of the minister as well. That's always a plus when you can do that.
Yes, Annette and I managed to get our photo taken with him as well. It's up. If you go to LinkedIn, you'll see Annette and I with the minister.
Okay, I can turn you into a cartoon if you like, George, to promote this episode. Did you like the last one that I did where you were Dr. House? And also I put us in Paris together.
My kids do love your cartoons.
Good. I'm glad they like them. Okay, well, should we get into our hot topics? We have a jam-packed show today.
Let's go.
All right, well, our first story comes from Portugal. And while it might sound like a story about physiotherapy, it's actually a real-life example about how we can deliver healthcare differently. We're talking about a genuine world first here. Portugal's National Health Service has signed a deal with digital health company Sword Health to make AI-supported physical therapy available to the country's entire population, all 10 million people. Under the agreement, any physician in Portugal's public health system can prescribe remote physiotherapy for musculoskeletal conditions, and the government is footing the bill. This service is free to patients after a medical prescription. And how it works is that after a referral, patients do their physio from home, and the platform combines AI-driven motion analysis with oversight from physiotherapists who evaluate patients, supervise treatment plans, and adjust them as needed. And during the sessions, the system actually analyses movement in real time and gives the patient immediate feedback on technique. So it's not a chatbot replacing a physio. It's actually AI supervising the exercise, and then humans are in the loop on the clinical plan. I love this because instead of AI just supporting healthcare delivery, it's actually becoming part of the healthcare service itself. And it's actually in physio, which a few years ago, if you said this was going to happen, no one would believe it. This is a really big deal, I think, because it's not a pilot in a single hospital or an individual health insurer trialling a new model of care. It's actually a national health system making a strategic decision to purchase AI-enabled care at scale to help address workforce shortages, improve access, and reduce waiting times. And George, I was thinking, we've covered a story a bit like this in the past. When was that? And I looked in our archives, and it's been 2 years and 2 weeks since our very first Pulse Pod show. And in that very first episode, we discussed the NHS trialling an AI physiotherapy service. But here it is 2 years later, and we're seeing an entire country move towards embedding a similar model into routine care. So my question here is, are we witnessing the beginning of governments buying AI-delivered healthcare rather than simply buying AI software?
I think it's a great story, and kudos to Portugal. Portugal is one of those countries which only 10 years ago was being written off in Europe as a financial basket case. And now it's demonstrating real innovation in healthcare procurement and doing it in a fiscally responsible way. The reality is countries like Portugal, and I note that Greece has also signed a contract with the same company, because they're under financial restraint, they've had to think outside the box. I touched on earlier the recent event with my relative in hospital. Now, access to physiotherapy, even in the hospital, was limited because of the sheer fact that there's so many people need it, and it is a very time-intensive process. So these AI-based tools really enable them to do it. About 15 years ago, up in University of Queensland, Professor Deborah Theodorou, who was doing some interesting research back then on using automation for physiotherapy. The classic model of telehealth was always a physiotherapist on one end of a camera and a patient on the other. But Deborah's work back then was looking about how much of that they could automate so that physiotherapists didn't have to sit there watching people doing exercises. And seems to be where it's going. So I think it's fantastic. Physiotherapy and allied health are really critical. We've seen a lot of work around AI, how accurate it is around diagnosis and delivering care plans. But the reality is, the process of rehabilitation, especially in those older people or those with musculoskeletal issues, is critical. And I've seen this a lot in the aged care sector. So I think this is a real prime example of how governments or healthcare services can leverage technology. The key thing, of course, here is the availability of technology. For this sort of thing to happen, broadband connectivity is critical, access to the right devices. You can't do this on an 8-year-old phone with a 4-inch screen. You need to have the right technology and the right devices. And I think the reality is the technology is available now, whether it's equitably distributed. Does an 80-year-old have access to this technology? If not, why not? What can we do to make sure they get that so that we get these services? I have to say, I actually did use a virtual physiotherapy service last year when I did my knee. And I was pretty impressed. It saved me that hassle of going to the local physiotherapist and waiting in the waiting room and trying to fit in an exercise program at a time that suited us both. So the actual concept of the service is great. Making it available to everyone is great. I think there's an opportunity for us here to learn from some of these other countries. So we tend to focus on what the UK is doing and what the US is doing. But Portugal and the countries like that are really coming up with solutions that are relevant and we can take advantage of here in Australia as well.
Yeah. And I'm getting Portugal in my feeds everywhere because we've got the World Cup and Portugal's game. Mandeep Hansra, a friend of the pod, went to Portugal recently and visited one of the startups that Medical Angels has invested in over there. A colleague that I work with just got married in Portugal, and Dua Lipa just opened a library in Portugal.
We need to visit Portugal soon, Louise. Let's put it on the agenda.
I think we should. Everyone else is doing it. Yeah, let's do that. And seriously, I do love that we talk a lot on this podcast about the business models of healthcare needing to change and how we need to design systems and think about the systems differently so that we can make use of these technologies and tools to deliver care differently and potentially better. So for a government to actually see this possibility and to act on it is something we're going to want to watch as well. So it'll be interesting to see the sort of studies that come out of this. And like you said, George, that equity doesn't become a concern, and how is that addressed to make sure people do have the right technology and tools to take advantage of this, and that can be rolled out to other countries as well and other jurisdictions.
The issue here is workforce scaling. Yes, in an ideal world, we'd love to have a physiotherapist sit with everyone who needs physiotherapy and take them through what needs to be done. But we just don't have that number of physiotherapists. We don't have the capacity to deliver those sort of services. The fact that you can do this at 8 p.m. in the evening rather than 9 to 5 when the normal physiotherapy practice is open. You can do it remotely. You can do it anywhere. But like I said, the key thing here, it goes back to that discussion we've had about digital maturity. We need to make sure that the sector is prepared and the technology is there. The reality is that consumer-grade technology is now at a level where we can use it for these sort of services. We just need to make sure that it's available as a public good.
Yes. And I remember our Prime Minister, Julia Gillard, at some stage said that budgets are all about priorities and what you choose to fund. And here we've seen an example of a health system choosing to reprioritise what they fund. And I don't know, is this additional expenditure or is it reallocation of expenditure to this service as opposed to doing it in a more traditional way? But regardless, it's a profound shift. So well done, Portugal, and we look forward to following developments on this.
And the reality is, if they didn't do it this way, then chances are a bulk of the population just wouldn't have access to physiotherapy services. So
most likely, yeah.
Funny you mentioned Julia Gillard. I was preparing a slide deck for a presentation I'm doing, and I came across an old image I have of Julia Gillard talking to me via what was then the Intel Healthcare. When they launched the NBN, one of the use cases for the NBN was to deliver healthcare services into the home. The demonstration at the launch of the NBN was me in Sydney talking to Julia Gillard in Tasmania over a dedicated device around healthcare. It was part of the mantra of the early launch of NBN. We haven't really taken full advantage of the fact that using the NBN to its full health perspective.
I love that. And for the young Pulse Potties, George, roughly what year would that have been?
2011.
2011. Okay. Some people will be listening going, I was in primary school then.
Yeah. As long as they don't say they were born then.
Yeah, no, definitely. I don't think we've got you to listen in that demographic. Okay, if our first story asks whether governments are ready to purchase AI-enabled healthcare, our next story asks an equally important question. Is healthcare actually ready for the responsibilities that come with using AI? So our next story is really two stories that I think belong together because both are about accountability. So who's responsible when AI is in the room? So firstly, from the UK and reported by a Health Services Journal, the first complaints about clinicians' inappropriate use of AI have reached professional regulators. Now, while the details of the individual complaints haven't been released, they reportedly relate to concerns around documentation and the use of AI during patient care. The UK's General Medical Council has received 8 complaints against doctors in 2025 and 6 more in the first half of 2026. And the Nursing and Midwifery Council in the UK has had its first 5 referrals. Now, in response, the regulator's guidance is pretty blunt. Clinicians, they remain responsible for their decisions when using AI, and they should be discussing its use and its limitations with patients. And I think that story connects to a Lancet Digital Health commentary by Swiss academic Mattia Andreolotti and colleagues at ETH Zurich, which argue that we're asking the wrong questions about AI. So the authors point out that most studies still focus on whether AI improves efficiency, documentation, or diagnostic accuracy, but far fewer ask the question patients actually care about. Does it actually improve health outcomes? And the authors are calling for stronger clinical evidence, ongoing post-market surveillance, and they suggest that health services may need dedicated AI governance roles to oversee safe implementation. So, George, I think put these two stories together, the complaints are arriving before the evidence base and the accountability frameworks are ready. We really need to sort this stuff out, and I would think pretty urgently.
Yeah, and this story does remind me of the Gartner hype cycle. Now, we've hit that peak where AI was going to save the world and change medicine. Bernard Kostler told us that doctors would become a thing of the past because AI will replace it. And we're now starting to slide down that trough of disillusionment. And nothing is as disillusioning to a clinician as a malpractice lawsuit or having a lawyer knock on your door. And I think this is where we're coming to. The reality is that people using AI now have to become accountable for their decisions. And whilst I agree that clinicians need to be responsible for their own decisions, we also need to push back on the idea that no responsibility is derived by those services which claim to be providing that intelligent support. They promote themselves as health support tools, clinical decision support tools. If clinicians are using them in good faith, often having paid for those services. There were, in the early days, lots of free services, but I'm starting to see less and less free AI services and more paid AI services coming to ground.
Just a matter of time.
So I think, again, the reality is if you're charging for these services and you're promoting it as support, then some sort of degree of responsibility. In that article, they talk about you should be having a discussion with your patient around how you're using the AI. But in the real world, in a 15-minute consult, there's not a lot of time to sitting there having long discussions around pros and cons. And what we need to do is actually ensure that the AI we're using is actually providing value, which brings us to the second part of that story around the Lancet article, that we've been so enamored by the fact that the AI can give us a 2-page document about someone's diagnosis and give us a whole bunch of links and references. It sounds like it's a very scholarly and a very well-knowledged clinical advisor, but in reality, we don't know whether it's actually making a difference. Is it just adding volume to our notes rather than adding value to our notes? I think that's where we really need to think about. And the Lancet article really highlights the need for research around outcomes, not research around areas under the curve. And we've seen all those sort of discussions, and diagnostic accuracy doesn't matter. Doesn't make a difference to the patient's outcome. I think these are the things we need to think about. And the reality is we need also to get that research embedded in early. So we are starting to see now there are journals specifically focusing on AI, and they are looking more and more into the concept of evidence-based medicine in AI. But the horse bolted. If 70% of clinicians are using this AI tool, and we've seen some numbers even higher than that, then we need to think about what we do about it. Keeping in mind that when there is a complaint, there's probably an AI-empowered lawyer on the other side that you're fighting against. So it could be your AI versus the lawyer's AI, and see who wins that one.
Yes, that's right. And it makes me think, George, it leads in really well to our next topic, because how can we be confident in digital tools themselves? Our next story follows on from Apple forcing health apps to declare medical device status, which we covered, I think, about 15 episodes ago or something like that. So exactly how big is this problem? The answer is it's big. So firstly, I wanted to thank our UK-based friend of the pod, Liz Ashell-Payne, for bringing this story to my attention. Last year, regulatory expert Rudolf Wagner analysed App Store listings, and he found that of nearly 96,000 apps that qualify as software as a medical device, 95% of them, 95%, had no verifiable CE marking or FDA authorisation, i.e. they're not regulated. Research shows that there may be a substantial gap between what some apps claim to do and the regulatory information available to support those claims. Now, this doesn't, of course, necessarily mean that the apps are unsafe or non-compliant. Some may well have the appropriate approvals, but they're just not simply obvious to consumers. But it does highlight a much bigger issue. Most people downloading a health app have no easy way of knowing whether they're using a regulated medical device, a wellness app, or something that sits somewhere in between. And Wagner's argument is that app stores aren't neutral conduits, or that they shouldn't be, that Google and Apple should be treated as importers and distributors of medical devices and made to check for things like CE marks before an app goes live. So as AI becomes embedded in more consumer health products, that distinction is becoming increasingly blurred. So if an app analyzes your skin lesion, or it monitors your heart rhythm, or provides mental health advice, should consumers be expected to work out whether it's been clinically evaluated? Should the app stores be making that much clearer? So George, we've been talking about accountability for clinicians using AI in the previous story. Well, perhaps we also need to ask who's accountable for helping consumers understand which digital health tools they can actually trust.
First of all, shout out for Liz and Orca. That's really important work they're doing around keeping an eye on what's happening in that app stores. And 100,000 apps that can potentially be deemed to have software as a medical device. That's amazing. And the reality is they use the old education-only disclaimer. This is only for educational purposes. So therefore, do not make any decisions based on this. But send us the $39.99 fee. And to be honest, we know the App Store takes a good 20 or 30% of that as well. So there's a lot of people conducive in this story about how this stuff's being used. Yeah, sure. There's an end user license agreement which flashes up on our screen. So they talk about this as the Wild West of digital health, and it is. And it is something we need to really take into account, because more and more people are relying on these apps for their healthcare needs, be that because they can't afford to go elsewhere, be that because it's so much more convenient, be that because the latest TikTok influencer has told them that this is the way to go.
Yes.
Ultimately, whose responsibility is it? The app stores do make money out of this, so they have a responsibility. As we've seen, the Australian government's highlighted this a couple of times recently. These big tech companies are very good at pushing away from responsibility, blaming it on someone else. So I suspect this is another one of those cases where they're not the distributor, they're not the importer, they're just a marketplace. In a normal marketplace, if you sell something which causes harm, there's a responsibility to be taken there. I think we also need to educate the market. I mean, we need to have a program where we tell people that this is what you need to look out for and this is the certification mark. Orca is a great example of having that sort of certification. This is high-risk area. This is not the Wordle games on your phone. These are high-risk areas. Look, I understand on the other side of the coin, the reality is that if you make it too hard for people to develop these applications, then we're going to have a decrease in innovation, and we need to somehow balance that. I guess this is where we really need academia, industry, and government to work together to develop some sort of framework where we can iteratively approve these apps going forward. It's a really important area because people are being harmed. We've seen issues in mental health and other areas where people are using these apps and are making clinically related decisions.
There are multiple countries that are looking at these issues. And yes, full disclosure, Liz Asher-Payne is a founder of Orca. But Orca does such a good service. Like, we're not giving them a free advertisement. It really is an independent, very thorough evaluation of health and medical related apps. And rather than a hospital expected to say, oh, well, okay, yes, there's 120 diabetes apps that will help you manage your diabetes, and the clinician being overwhelmed with which of those 120 is right for my patient, or we're just going to pick one and we'll make that the winner. That shouldn't really be a hospital prerogative. We like consumer choice. But if you can actually go to an independently verifiable source and know that, oh, okay, out of these multiple different diabetes management apps, this one rates a bit lower because maybe patient privacy is an issue. But maybe, you know what, I don't care about my patient privacy. I love the interface or the gamifications, but at least I'm informed and I can make that choice. Whereas someone else who might go, okay, it's a bit of a crappier interface, but privacy is super, super important to me. So now I'm informed of that information, I'm going to use it. And I would hope that we can see more governments around the world, including Australia here, actually adopting these types of systems and not needing to reinvent the wheel either, but just let's inform people, give them relevant, independent, verifiable information, and they can make their own choices.
Talk about digital therapeutics, but unless we actually have some sort of standards to place prescribing on, it really is the Wild West. And we know in the Wild West, those of you who saw the movie, snake oil salesman predominates. So we need to make sure we don't go down that pathway again.
That's right. And as we've seen with the rise in social media over the last decade, that trust is everything. And this is all about consumer trust. And with AI increasingly being more embedded in our everyday lives, let alone our healthcare decisions, again, we shouldn't be doing anything that could undermine public trust in healthcare, and including in the technologies that are being utilised in health or being promoted that they will help you. So let's hope that we can get some traction on this. And big shout out, Liz, to Rudolf Wagner. And thank you for doing the work on that, Rudolf. And we will put a link to it in the show notes for anyone who wants to read through the original source. Our last story asked whether patients can trust the digital health tools they're using. Our next story after the break looks at a different challenge because patients are generating high-quality health data from trusted devices, yet we're still struggling to answer a really surprisingly basic question. How do we actually use that information in everyday clinical care? So we're going to look at whether doctors want to use the wearable data their patients are collecting every day. And we're also going to look at whether virtual care could transform life for older people living in residential aged care. Back soon. Welcome back, everyone. We talk a lot on the pod about wearables, and we've also mentioned the fourth wave, if you remember the bioforecasting story from a few months ago. Well, our next story sounds like it's about wearables, but it's really about something we've been talking about on Pulse for years, patient-generated health data. Now, a new survey from the American Medical Association has found that doctors increasingly believe that data from smartwatches and other wearable devices could actually improve patient care. But despite their enthusiasm, very few clinicians are actually able to use the information that their patients collect in their everyday practice. The survey of over 2,000 physicians across US, Canada and Europe found that cardiologists and endocrinologists were the specialties most likely to use wearable data in care. But while 97% of physicians said they'd review health information collected by a wearable, unfortunately only 6% in any country had actually integrated that data. So that's 97% are willing, but only 6% are actually doing it. And the US, more than 8 in 10 doctors use actually some kind of wearable themselves. So of course, the reasons here aren't technical. It's not because the watches don't work. It's because the data doesn't naturally fit into clinical workflows. It doesn't reliably flow into electronic medical records. And clinicians, they don't have time to review hours of heart rate and sleep data. There's almost no or very little reimbursement for doing so. And of course, there are still questions about liability if clinically important information collected by wearables is missed by clinicians. Now, just last week, we spoke to Hugo Campus about patients fighting to access data from their implantable medical devices. And Hugo's whole argument is that patients should own their own health data. Well, increasingly they do. Millions of people across the globe are actually walking around with these wearable devices that continuously collect information about their health. They're getting more and more sophisticated. And the challenge, therefore, shouldn't really be about collecting the data. It's making that data clinically useful. George, do you think we're going to reach that point where interoperability is no longer just a conversation about hospitals sharing information with hospitals and with primary care, but actually about patients becoming one of the most important sources of health data in the system and the need to interoperate technically, but also at a clinical workflow level?
Wearables have been around for quite a while now, and you're right, most doctors wear them. The number of people I've seen wearing a classical watch nowadays is diminishing. What they do has significantly increased. So the article describes a number of the barriers of adoption. Yeah. And the one that we've been hounding for many years, and I go back to when I was working at Intel, back when we set up the Continual Alliance, is one around data standards. So the reality is, yes, there are dozens of different types of watches out there, but do they all have data available in the same format? Is there an expectation that the clinician will have to work out how to standardize that data and to be able to integrate it into their system? So going back to work that's been happening for 20 years and for some reason didn't ever quite get over the line, and whether that's cultural or whether that's commercial, and some of it was just related to data quality. For 20 years, we've been working on trying to develop usable standards for these devices. There are so many tools out there that patients or individuals, consumers can use at home to capture information. How do we make sure that information, one, is high quality data, two, is transmitted in a way that can interoperate with all the other services out there? And the mere fact that 90% of clinicians have a watch, but only 6% of them use it clinically, tells us that there are a number of challenges there. So first of all, let's solve the data quality and the data standard. Fire has gone a long way along that line, and I know Apple's been a strong supporter of the Fire standards. Again, shout out to our good friend Graham Greene, but the reality is that's probably the first step we need to do. Once we've gotten past that, we need to start thinking about the other barriers. And you touched on them really well, Louise. Reimbursement is a barrier. That data has huge value to a clinician, but for them to spend the time to analyze that data and use it to make a clinical decision, in the current fee-for-service model, they don't get paid for that time spent making that decision. So we need to start thinking about how clinicians are reimbursed in a data-rich world where they're making decisions not necessarily whilst the patient is sitting in their room. In Australia, we have that current restraint that the patient either has to be sitting in the same room or has to be on the other end of a phone line or a video camera. But clinical decisions can be made in different ways, and taking advantage of the information, that rich environment we have, is a critical part of that. I think one of the other key limitations we have is the digital maturity of the sector itself. Clinicians need to understand what this data set they have access to is capable of. And as we talked about earlier, having evidence base that it actually makes a difference. So making sure we develop research in this space that demonstrates the clinical value of this, be it wearable data, be it environmental data, be it the huge plethora of other data that we now have access to. What is the evidence that it actually makes a difference? And I think this is where we really need to start focusing some of our research on now. Of course, the big elephant in the room, and we touched on it, is reimbursement. Who pays for the technology? Who standardizes the technology? Who pays for the system to collect the information? Who pays for the clinicians' times? That's all important. But I think most clinicians, if they see that it provides value to their patients, and most clinicians still think of the person they deal with as a patient. I know we've had lots of discussions about what the right terminology is. They will utilize the technology available to them, but we need to provide them with the education and the resources to do so. And that means that we have to think about how we drive research in this space.
Yes, absolutely. And we want to see more of this, don't we, George?
Absolutely, yeah. And we've seen some great research. And Hugo's Campus's work is a great example of that. I mean, with an implantable, we're talking about not wearables, but basically insertables. There is a lot of information. We just need to start thinking about what data-rich environments mean to healthcare delivery. And that means driving that innovation from within the clinical world, not just the technology world.
Yeah, absolutely. Were you suggesting that maybe this is something for Spark to look at? We're looking at interoperability in the Australian government rather than just looking at the healthcare vendors that work in enterprise-based systems. We should be looking at this.
Absolutely.
And regulation needs to get involved.
Just remember, My Health Record started off as a personally controlled electronic health record. The reality is, and we've said this so many times on our podcast over the years, the health consumer is now a vital part of the whole health system. We need to think more and more about how we engage them in their own healthcare. And the key part of that is making sure the data that they have access to is high quality, high value, and properly utilized. So I think we have an opportunity here for have a Spark consumer drive as going forward, and Spark being the standard for all the health data out there. We've seen FHIR adopted around the world. It needs to be even broader so.
I like the fact that for 20 years we've focused on making health systems talk to each other, and we have not yet resolved that. But yes, Sparked and FHIR and globally, there's a lot of work improving interoperability. But I'd love to think that the next decade, maybe we can focus on utilising digital so that health systems can listen to patients. That will be a real game changer. So let's see how it develops, and we will continue to cover these themes here on the pod. Well, our final story today explores virtual care transforming care in residential aged care, where the challenge isn't collecting more data necessarily. It's about making specialist care available to some of our most vulnerable patients without them needing to leave the facility. So we go back to Australia for this, and appropriately back to patients. As reported by Heather Fletcher in Pulse IT and published in the Journal of Medical Internet Research, Australian researchers have looked at virtual care between residential aged care facilities and GPs. And they found considerable upside. Virtual care was seen as improving access to care, reducing unnecessary hospital visits and saving GP travel time. But the barriers, they're substantial. Poor system integration, usability issues, unreliable networks, inconsistent processes between homes and the GP practices, and of course, limited staff training. Does this sound familiar? It's like our wearable story all over again. The technology works, but the system around it does not. So making virtual care routine in aged care requires so much more than just simply putting in an iPad in a nursing home. It depends on staff training, clear clinical workflows, reliable technology, leadership support, and making sure virtual consultations fit into the way aged care actually operates. And of course, this all might sound obvious, but I do think it highlights that some of the biggest lessons we've learned in digital health over the last 20 years is that technology rarely fails because the tech doesn't work. It fails because we don't redesign the system around it. And I've mentioned before on the pod that my very first job in digital health was evaluating the telehealth rollout in Western Australia. This was over 20 years ago when an iPad hadn't been invented. This was big systems, big tech, big enterprise, expensive systems. And even in those days, it was like, yeah, the tech works, but, sending someone to a 10-minute training session and then don't give them a reason to use the technology for another 12 months. And then you're surprised that they don't know how to do it and they resist using it. And we would do workarounds instead. In today's episode here, we've talked about governments funding new models of care, accountability for AI, trusted digital health apps, and integrating wearable data into clinical practice. And then this story, I think, brings it all together, George. We've got digital transformation. It's not about introducing new tech. It's about changing the way healthcare is delivered. And it's about service redesign. George, you're the aged care expert here. What are your thoughts?
A bit of a disclaimer here. I do know the authors of this paper quite well, and I was aware of the work they were doing. And I do believe this will actually become one of those seminal papers in the virtual care in aged care space, because it's really a great example of proper research around how this can make a difference. As you know, I spend quite a bit of time in aged care, and the reality is we are in a real crisis at present with regards to residential aged care. The estimates tell us we need thousands of more beds, but the cost to develop those beds is astronomical. And even if we did build the residential aged care facilities, the staffing to fill them is just not available. So we have a real dilemma. Potentially there are tens of thousands of Australians who need residential aged care in the near future. The baby boomers are coming, as we've heard over and over again. Yes, we are doing home-based services, but even that has its challenges. And this paper suggests that using virtual care in these facilities as part of an integrated care model, and that's the key word here, the integrated care model, that's the challenge, because at the moment, we don't have an integrated care model. And even though we have a Department of Health, Aging and Disability, those three parts of the department themselves don't collaborate and cooperate very well, yet alone the delivery parts of it. And because each of those delivery parts is a separate public or private entity which is under federal or state jurisdiction, or is a commercial versus not-for-profit organisation, there are just so many challenges there that we have this fragmentation unless we can develop that integrated model. And as this article highlights, the technology isn't the issue. The example I gave earlier today, my relative in hospital, with the right people in the right place, and thanks to the work of amazingly dedicated staff, you can make it all work. Now, I suspect in that case, the fact that the family member was a doctor and also the chief technology advisor for the aged care peak body helped. It does grease some of the wheels, but we need to make that level of service available for everyone. Now, the article talks about this concept of invisible work. There's a lot of stuff that happens behind the scene to make this work that we need to make visible, because if we don't know what's happening behind the scene, A, we can't standardize it. B, we can't automate it. C, we can't fund it, because if we don't know what's happening, then there's no funding model around us. I can't go into too much detail, but there was a major initiative launched a year or two ago, specifically looking at delivering virtual care into residential aged care facilities. It had huge promise, but they literally wrapped it up and closed it down a couple of months ago because it just couldn't become financially viable. The system wasn't in place to enable this solution to provide the care. Those who used it loved it. Those who used it waxed lyrical about how effective it was, how it saved workforce time. But the current funding model for nursing in residential aged care facilities didn't recognize virtual care. So therefore, this was not a cost-saving exercise. It became an extra cost because it was an unfunded service. This paper's done a great job at looking at all the barriers and drivers. I think it's got some really good recommendations. I'm actually making sure that the people who wrote this paper will be presenting at the Aging Australia National Conference in November in Sydney. And I think we need to make this the basis for us to really start thinking about what virtual aged care looks like in residential aged care. Because as the people I'm watching aged in Australia now, they're just not getting the care they deserve.
Yeah, which is not good enough. George, great you know the authors, because I note Adiola and her colleagues. You think, are they from the School of Nursing? Maybe they're from the School of GP. No, they're actually within the Design School of Architecture, Design and Planning at the University of Sydney, not clinicians.
I need to give a shout out to the School of Health at Sydney University. They've really gone multifactorial. They've expanded outside of scope. They're working with various organisations. In the old days, the medical school did research within the medical school, but Meredith Makeham in particular, who's part of the School of Medicine, has really looked outside the box and realised that healthcare is a very multifactorial issue. And you're right, architecture and housing, if where you live is an unhealthy environment, then I can give you as many antibiotics and antihypertensives as you like. If your house is killing you, then there's not much I can do about it. So we really need to think about those social determinants of healthcare and the broader aspect of health. If you look at the WHO definition of health, it's not medical, it's social. So we need to think about those sort of issues.
Yeah, absolutely. Well done, authors, and great, George, that you can use some power that you have as well to highlight the work they're doing and give it a bigger platform. All right, well, today's stories, I think we're really talking a lot about the same thing, which is how health systems absorb innovation and turn it into better care. And I think that some of the key takeaways are that we must just continue to ask and resolve the hard questions and do better on implementation. So governance, trust, redesigning care itself. So, the idea with a lot of these stories we've covered today is, of course, technology isn't really the biggest challenge. It's the actual health system that is. So, George, what about recommendations? Do you have any recommendations for the Pulse Potties today?
A newsletter called TAAFT, TAAFT. And what it stands for is that there's an AI for that. It's quite an interesting newsletter. It highlights the huge number of AI tools that are coming out. And it's just amazing, the sheer volume of tools. But it also has some really interesting stories. It came across a story about an article of 16 Nobel laureates who are warning about an AI tsunami. So it provides quite an interesting view of what's happening in the AI world. I think it's a daily newsletter. I still do there's an Australian AI newsletter called Age Friendly Futures by a friend of mine, George Kazunas, which I highly recommend for those who are looking specifically around AI in aged care. But this one is a much broader AI newsletter. Highly recommend it for a bit of light AI reading.
Oh, thanks, George. We'll put a link to it in the show notes, which would be great. I've got 3 things I wanted to let people know about. So firstly, you can participate in some research. Researchers from Monash University, headed up by Rashina Hoda, a professor there, she and her team are doing research into clinicians' use of AI. Now, the survey only takes 10 minutes. If you're a doctor, a nurse, allied health professional, or any healthcare professional, they want to hear from you. We will put a link to it in the show notes. And it is global as well. They're collecting data from a global audience. So wanted to give a shout out to that important research, and please have a look at the show notes. And if you're a clinician, consider taking 10 minutes out of your day to tell us your thoughts about AI. So there's the plug for the research. I also wanted to give a big shout out to people who have worked on the telehealth standard. So Australia now has a published standard for the use of telehealth and virtual care. And it was developed by Standards Australia's IT 1420 subcommittee on telehealth management. So we will put a link to that standard in the show note, and just wanted to shout out to everybody who worked on that diligently over, actually, I think many years. So well done and thank you. And the third thing, nothing to do with digital health, but everything to do with football or soccer if you're in Australia. The World Cup is on Monday after this podcast recording comes out, will be the finale. There is a World Cup song. It was in my Instagram feeds, to be honest. It just made me feel so good. We'll put a link to it in the show notes. I wanted to suggest people check it out and don't listen to it. Actually watch it. It's on YouTube as well as all of the socials. It's by American Jason Stills. Now, it does have a very American title, this World Cup song. He's called it Welcome to the Land of the Free, but it's a country and Western sort of upbeat banjo beat, and all the lyrics and the videos accompanying it are all stories from people who are visiting the United States for the World Cup and all the cool things that they're doing, like Norway with their row. I did notice the Australians are missing from the tribute in the song, probably because they said things about Donald Trump that maybe Americans might not want to hear. So Australia didn't get a mention, but lots of other countries did. And it made me feel good. It was very like we're all coming together and the globe is joined together doing something really special and sharing this special event with each other. So it made me feel good. And I wanted to give a shout out to Jason Stills for putting it together. So I will put a link to it in the show notes.
I was up at 4:00 in the morning last week watching Australia. Kudos to the Australian team for doing as well as they have in a very challenging area. A friend of mine pointed out that when we played Egypt, that the one player in the Egyptian team earned more than the entire Australian squad combined. So we did pretty well for ourselves.
Yeah, that's not bad. Yes, I have been enjoying watching the World Cup. And because I was in Europe and the UK, got to see games with the locals, like going to the local pubs and just seeing the excitement and being part of it. So I will be getting up early on Monday mornings. I think it's 5 a.m. our time, George, Monday morning.
And a shout out to those innovative Australians and their chants. So they were interesting, weren't they?
I'm very proud of their chant. Well done, Aussie blokes, on a bender. And we'll let you decide, everyone, what actually rhymes with bender. All right, George, great to chat to you as always. Thanks for joining me for such a jam-packed show. If you could please read us out.
Welcome back home, Louise. Great to have you back in Australia. Thank you all for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurek of Octopod Productions. Thanks to Emily Mara for her support. Big thanks to everyone for listening. Make sure you subscribe, follow and rate us wherever you get your podcast. Visit pulseit.news to catch up on the news from Australia, New Zealand and Ireland, and send any feedback or topic suggestions to pulsepod@pulseit.news. We'd love to hear what's on your mind. Bye everyone.
See ya.